Hi, I'm Dr. Salil Khandwala, and I am the medical director at Advanced Urogynecology of Michigan. We subspecialize in female pelvic floor dysfunctions, and a lot of our information can be found on our website, www.augm.org. Today, we shall be discussing this commonality between incontinence and bladder pain syndrome. Let's begin with looking at the anatomy. So as you can see here, these are the two kidneys, one kidney on each side. The kidneys essentially filter the blood and produce urine. The urine is then transported by these two tubes called the ureters, one ureter on each side arising from each kidney. The two ureters then drop the urine from the kidneys into the bladder, and the bladder then stores the urine. So this is the urinary bladder. The urethra is the tube that brings the urine to the outside, and that stays tightly closed as the bladder is filling up. Only when the bladder is ready to empty at the time of urination does it actually contract and the urethra relaxes and the urine comes out. And this is under the nervous system control. So this is a side view of the female pelvic anatomy. So looking at the front is here, the back is here, the top is here, and the bottom is here. And you're looking at a woman in profile or from the side. This is the bone in the front called the pubic bone. Behind that is the bladder, which is this organ right here. The urethra is the tube that brings the urine to the outside. The vagina is behind that. The uterus is on top, and then the rectum is at the back, and then the buttocks. So this is the typical orientation of the female pelvic organs as seen from the side. So what is stress incontinence? It's essentially leakage of urine that happens with any strenuous activity such as coughing, laughing, sneezing, lifting, which is involuntary. That means the patient doesn't want it to happen, but it happens, and that is stress incontinence. There are two types of stress incontinence. One is called hypermobility, and second is where there is weakness of the sphincter. So hypermobility is, for example, this is the bladder, this is the urethra, and this is the pubic bone in the front. So when a patient strains, the tissues should hold it in place and prevent this junction from dropping down too much. However, if the tissues have weakened, then the junction drops down significantly more, and if it is beyond an angle of 30 degrees to the horizontal, it's called hypermobility, and that causes urinary leakage. So how does that happen? So again, you're looking at the pelvic viscera from the side. This is the front, this is the pubic bone, this is the bladder, this is the urethra, the vagina behind that, uterus on the top, and the rectum at the back. With that orientation, this is the top. So when she coughs, the pressure comes down onto the bladder. The dotted line is where the bladder, and the dotted line here is where the urethra are at rest when she's not straining. Now when she strains, typically the tissue supports should prevent it from falling down and hold it in place very close to where the dotted line is. However, if the tissue supports are weak, then it'll let it fall back, and as you can see in this case, the junction drops from here to here. It funnels open the urethra because the tissue supports are weak, and that results in urinary leakage. That is what is this hypermobility. The urethra doesn't stay put, it falls down like in this case, and because it falls down, you have urinary leakage. This is called hypermobility stress incontinence and is one of the most common types of stress urinary incontinence. Again, remember, when we say the word stress, it's not mental stress, it is effort, stress of physical labor or activity. Now, with the sphincter, if the urethral sphincter is weak, so as you can see, this is that urethra, this is a normal sphincter which is tightly closed, and this is a sphincter muscle which is relatively weak. So with a weak urethral sphincter, the urethra itself is at fault and the urine would come out. This is very common. Urinary incontinence affects at least 1 in 3 women, so you are not alone. So what we have done today is done the history and examination. For example, we gave you this form to fill out, and we broke it down into the urgency, the gotta go part, and the coughing, sneezing part, and then we came up with a score. Then we did this form called the urogenital distress inventory, and we looked at different aspects, whether it's frequent urination, urine leakage with urgency or with coughing, and if there's any pelvic pain, and then you graded it so we got an idea as to how much this is bothering you. Then we did the examination initially in the lying down position, and then if required in the standing position to see whether there is any incontinence if it was not noticed in the lying down position. The next step is to keep a urinary voiding log or voiding diaries, and that requires using a hat which is placed under the toilet seat. We call it a hat. It's interesting, isn't it? It doesn't go on top of the head, but it actually sits in the toilet seat. It's called a voiding hat, and it has measurements. So when you're actually urinating, you can measure it, record it, and then throw it out. You do not have to collect it. And that amount is what you will put on this particular line. This is, you will state when you went to the bathroom, how much you urinated in that hat, and if there's any leakage, you'd mention it as 1, 2, and 3, and this is your log. 1 is essentially small, medium, or large. At the same time, you'd mention if there was any urgency, a yes or no, and what were you doing? Were you on the way to the bathroom? Did you give a cough, or what was going on when you had the urinary leakage? Finally, so this is all about the first 5 columns are about urine leakage and urine production. The remaining 2 columns are as important because they discuss about how much you are drinking in a day, and also what are you drinking? Are you drinking caffeinated beverages? What exactly was the liquid that you had that particular time when you had it? So for example, let's say at 8 o'clock you had a cup of coffee, then you'd say it'll be 8 ounces coffee would be what you would write here. The 3-day diary is a logging of the bladder activity over 3 days. Now this is only bladder activity. At the same time, you do not have to measure. So there is no detailing to be done. All you need is a paper and a pen, and you just note it when you go to the bladder or if you have any leakage. So let's take this example where this patient wakes up at 6 o'clock in the morning, and then she goes to the bathroom and empties her bladder. That's why she puts an E. Then at 8 o'clock, she coughs and she leaks. That's why she puts this S. S is when you leak with cough, sneeze, or exercise. E is again, she goes and empties her bladder. At 10 o'clock, she empties her bladder 2 times. At 11 o'clock, again, she strains and she leaks. At noon, she has U1. U is urgency, is when you leak a few drops. U2 is when you leak a little bit more. And U3 is when you completely soaked your pad or your underwear. So here is U1, then she empties and has a cough leakage. Then she again has cough leakage. Here she empties, she has urgency leakage, a little bit more than just slight. And then this goes on. And at nighttime, she goes to the bathroom 2 times. And during this entire episode, she had to wear 3 pads. So this is one detailed information without any measuring that is done over a 24-hour period. And we do this over 72 hours. Once we have that information, then we try to correlate your voiding diaries and your findings on examination with what is called urodynamic testing. This is when we fill the bladder up with water and we have an EKG, like pressure recording of the bladder, the abdominal muscles, and the urethra, and then come to some conclusion as to what is causing your symptoms. Finally, I may do something called a cystoscopy, which is looking inside the bladder. So here's a patient lying down. This is her head. So both of us are watching on this TV monitor, and we are watching at this bladder. So this helps us make sure that there is nothing intrinsically wrong with the bladder that could be causing your symptoms of urinary leakage. So the stress incontinence is extremely common. It affects younger women, women of all ages. So it's not something about just the elderly patients. These are the ladies who cannot do jumping jacks, cannot run because they're leaking urine. And you know what? Treatment has dramatically improved. Our results are almost 100% success done in an office-like setting. There is minimal downtime, and it's like a drive-through procedure, as one of my patients called it. So question is, then why wait? So that is the information about stress incontinence. Let us change the topic over to bladder pain syndrome, or also what is called pelvic pain syndrome. So this is where there is pelvic pain, pressure, or discomfort, which is felt to be related to the urinary bladder and has one other urinary symptom, such as increased daytime or nighttime frequency. And this is key. The key is that it's in the absence of a bladder infection or other obvious pathology such as a bladder stone or bladder cancer. What happens is there's an interplay between the A fiber and the C fiber. So let me tell you a little bit about these nerves. So these are the nerves. The A delta, it's called A delta nerve fiber, basically carries a sensation of pressure and touch. So if you're sitting on a chair right now, you can feel the chair, but while I was talking and explaining you to this, you could ignore the chair. And that's what this A fiber does. You can feel it, but at the same time, you do not have to pay attention to it. In the bladder, it is the fullness. So as you are listening to me, your bladder is getting fuller and fuller, but you can ignore it because the A delta fibers can be overwhelmed by normal sensations. So you can allow it to fill, and even if there's a desire to urinate, you can still curb it. C fiber is very different. C fiber is a nerve that you have to respond to. It carries the sensation of pain and temperature. So in the bladder, it is the urgency. So as the bladder is filling up, you'll feel intense urgency that gets even more urgent to the point that it becomes painful. So now these nerve fibers you have to respond to and you cannot ignore. So that's the C fiber. So when normally what happens as the bladder is filling up, the A fibers are active, and that's why you can sort of hold your bladder and hold it. However, if the C fibers for some reason become active, as it happens in patients with bladder pain syndrome, then you know what? There's no waiting. The fullness changes to severe urgency and discomfort and pain. So this is the problem. Normally, the A fibers are active, C fibers are not. So you can withstand, there's no discomfort, there is no pain, and you can hold your bladder. However, if the C fibers become active and there is nerve imbalance, then you have more discomfort, more pelvic pain, and that is the basis of bladder pain syndrome. One of the other things that has been considered as a cause of bladder pain syndrome is inflammation or the injury theory of the bladder lining. So here what you're looking at is this is the bladder wall. All around is the bladder wall. This is that urethra tube that brings the urine to the outside. You're looking at the lining of the bladder. So this is the lining called the urothelium. So it's usually very intact, and it has got a layer called the gag layer. The gag layer essentially insulates the bladder wall from the urine in the cavity. So it protects the nerves and the wall. However, if there is a breakdown of this wall, as can be seen here, so if the wall is right here, the gag layer breaks. See, there's no gag layer here. This layer up here, it's missing. So when that happens, the urine starts irritating the cells of the bladder wall, which is right here, and that gets transmitted to the nerves, and that is when the C fibers become active. So where all does it the effects? When we talk about the bladder, it causes urgency, frequency, discomfort. There is no urine leakage, but the symptoms are very similar to what a patient feels when she has a bladder infection or a urinary tract infection. So key thing is there is no urine leakage. She can hold it, but on the way she may leak a couple of drops, but not substantially. Vaginally, there could be discomfort at the vaginal opening and discomfort with deep penetration during intercourse, and that is called dyspareunia or pain during intercourse. At the back, in the bowel area, it can cause IBS-like symptoms, constipation or diarrhea alternating. And in the pelvic area, it can give rise to a sensation of pelvic pressure, pelvic discomfort, pelvic pain, and even a sensation as though something is falling out of the vagina. Remember, because of the excessive sensitivity of the vulva, which is the vaginal opening right here, so you can see this is a typical female anatomy, and you're looking at the vaginal opening. These are called the labial lips. This is the inner lip, and this is the outer lip of the labia. This is the hymenal ring right here. Inside is the vaginal cavity. This is the urethra, and this is the clitoris, and this is what's called the mons pubis, where the pubic hair is. This is area is called the perineum, and then you have the anus opening. Now, just touching at this vestibule, what's called at between the labia, at the vaginal opening with a Q-tip, barely touching it can cause significant discomfort. Why? Because the C fibers are active. So just touching results in pain. Now, when I'm doing a bimanual examination, so I am doing a vaginal examination, so when I press up towards the bladder or press down onto the bladder, that causes pain, and that's called bladder tenderness. So this is what happens also during intercourse. So when your partner is moving inside, all he's doing is he's just going in, touching the bladder, but the touch feels like pain because it's not the A nerve, but it's the C nerve that's carrying the sensation. Because of the pain, the muscles then go in a spasm, which is typical, right? Someone's coming to box you, you're going to brace yourself. That's exactly what happens here. Your muscles go in a spasm, and when the muscles go in a spasm to protect you from harm because of the pain, then the spasm remains. And once the spasm remains, the spasm itself can cause discomfort, pelvic pressure, and pelvic pain. So what do? So we talked about the urinary voiding diaries and the urodynamic testing that I mentioned, the cystoscopy. We also send the urine for analysis. Sometimes if the patient has blood in the urine or a history of smoking or a family history of bladder cancer, I may send the urine for cytology to make sure that the cells of the bladder wall are fine, and we make sure that there is no urinary tract infection by sending the urine for culture. So these are the very similar tests that I discussed earlier on. The key thing is this condition has been misdiagnosed mainly as bladder infection. There are so many women who I have seen coming to my practice who have been treated for years, not months, but years, with bladder infections. However, they've never had a bladder infection. So they've taken antibiotics after antibiotics, and the diagnosis was bladder pain syndrome. So be careful. Whenever your doctor recommends an antibiotic, make sure that if the symptoms continue, then you must make sure that the urine is sent for culture. To further review this, please review my talk on urinary tract infection on our website. It is also misdiagnosed as pelvic prolapse, because if there's a slight bulge, then you feel, oh my God, my whole vagina is falling out, and gives that sensation of pressure and something is falling out, even though the bulge is not the cause. Remember, pelvic organ prolapse never, or I would say rarely causes pain and discomfort. Prolapse is essentially something falling out, so you can feel it coming down. It is more of an issue that you don't like it hanging between your legs, but bottom line, it does not typically cause pain. Same thing with overactive bladder. When we say overactive bladder, that gotta go sensation is, yes, you see that with bladder pain syndrome, but in this case, it's the urgency incontinence. So a woman with bladder pain syndrome is not going to leak. However, they're still managed with medications which are typically given for women who have urinary leakage. A bladder pain syndrome will have the urgency and the frequency and that gotta go sensation, but she is not going to leak. Her problem is more nerve driven. With overactive bladder, it's more to do with the abnormal contractions of the bladder muscle. And some of these patients have also been diagnosed as endometriosis. This is the key thing, the misdiagnosis. So stress incontinence and bladder pain syndrome are independent problems. That's very, very important to understand. Just because you have urinary leakage with coughing, that is not the cause of the bladder urgency and frequency, and vice versa. They occur very commonly in women. And there is a lot of misdiagnosis, but they occur very, very commonly, and we see this a lot together. They're often misdiagnosed and mismanaged. Sometimes discharge may be considered as incontinence. Remember, the vulva is so sensitive. Just a little bit of vaginal fluid coming in contact with the vulva can make you feel exaggerated response where you think, oh my God, there's a lot of fluid. And then you feel as though you have urinary leakage. So yeah, there may be stress incontinence or they may not be, but we will figure out through the test that I've recommended. The management for both these conditions is very different, and the management depends upon which is your bothersome complaint. Again, you may be bothered by both, and both can be treated very effectively and efficiently. So both are managed together or sequentially. So the key thing is for you to do is make sure you review my information that I've provided you, read the educational material or watch the educational videos, and then we'll tailor it based upon your condition what is bothering you and your medical comorbidities. Remember, ultimately, both these conditions are very common. Both these are very straightforward to manage. However, I need your help to make sure that these are done correctly and these are managed appropriately. And to help me, you have to make sure that you do the diaries correctly, you come for the tests and read the literature that I've provided you. So then you are well informed. And a well informed patient, a well educated patient, is always an ally. And you will then help me help you.